Hi, thank you everybody. My name is Sashveen. I'm the Tropical Infectious Disease Advisor for MSF France. It's my great pleasure to welcome you here to Epicentre Scientific Day Malaria session, where some pivotal malaria research collaborations that Epicentre has been involved in will be presented, and as well as some key reflections from two esteemed colleagues in particular that are joining us here today from the Ministry of Health in Chad, who I'll introduce a bit more formally in just a moment. We will have the chance for some questions as usual, but please save them to the end of the session and we'll have a focused discussion. So our first presenter today, I would like to introduce you to Erwan Piriou. He is the coordinator of the lab and NTD team in MSF Holland, and also a core and valued member of our intersection malaria working group. He's been supporting the implementation and maintenance of diagnostic services in MSF for 10 countries since joining MSF in 2011. Before this, he was involved in research in immunology and co-infections. He's been invited today to present the results of the surveillance of diagnostic deletions and the presence of artemisinin resistance mutations. And this is a collaboration between the Ministry of Health in South Sudan and MSF and Epicentre. Erwan.
Hi, everyone. First, thank you for inviting me to present this survey, which was worked by all 5 operational centers present in South Sudan and Epicentre, to look into a concern first from our clinicians and a more global concern. So it's about the prevalence of Plasmodium falciparum HRP2 and 3 gene deletions in South Sudan, and I'm happy to present those results today. I will not talk about K13 deletions, but if there are questions, we can also answer them. So malaria is a big problem in South Sudan, as we all know, with almost 10 million suspect cases in 2022 and 3 million confirmed cases and almost 4,500 deaths. And MSF, it's one of the things we do a lot in South Sudan. So we've been treating more than 300,000 malaria cases in 2022 and 2023. There's a high transmission rate, which is more seasonal in the north and more year-round, although endemic in the south. And as far as we know, it's almost exclusively by Plasmodium falciparum malaria. So why this survey? Well, because the most used malaria diagnostic in South Sudan and in many African countries is the HRP2 RDT, the histidine-rich protein 2 detecting test, which is a protein produced by falciparum only. It's produced in high quantity, and it allows to produce very solid tests that keep well up to 40 degrees. There's a lot of brands that are WHO pre-qualified. So that's a good reason to have it in a test. Of note that these RDTs also detect HRP3, which is a related protein also produced by falciparum, and this is an important thing to remember. So what's the problem is that there are parasites that start having mutations and deletions in these genes, which were first identified in Peru and have since been identified in many more areas, and especially in the Horn of Africa and more broadly in Eastern Africa. There's not much data of use about South Sudan in terms of the impact of these deletions. And as you can see on the map here, this is a WHO threats map, which has a lot of studies or surveys available in the public domain, but their use is very variable because not all of them have been designed to look at actual impact on diagnostics. But what is known is that in Ethiopia, in certain regions, in Djibouti and Eritrea, and possibly in Sudan, there is issues with this. And the countries I named before have switched to different types of RDTs. So the impact basically is that if the genes are deleted, the proteins are not expressed, and you get a false negative RDT result if the parasite does not express their genes. So why are we not simply switching to other RDTs? It's because there is mostly one alternative antigen that is detected by RDTs. It's the PLDH, the Plasmodium lactate dehydrogenase. which is produced in lower quantities and harder to detect. So there are different reagents that detect multiple species or vivax or falciparum only. So the biggest problem is they have a higher limit of detection, so they will miss low-level infections. This is why the WHO recommends switching from the current HRP2 test to PLDH only if more than 5% of cases are missed by HRP2 compared to an alternative diagnostic, because you're missing the low level versus missing the deleted parasites. So how was this survey done? It was based on the WHO standard protocol for monitoring of PFHRP2 and 3 deletions. And the main objective, again, was to determine whether more than 5% of infected cases would be missed by HRP2 tests compared to an alternative test. In this case, the alternative test was a P-falciparum PLDH RDT, because microscopy was not feasible in the remote sites and with the unstable context. So it's not a perfect gold standard, it's a comparator test that also detects falciparum. And this was done across 10 sites in South Sudan, mostly in the north, northeast, and 2 sites in the south. So the inclusion criteria were fever or reported fever in the preceding 2 days, and generally children under 5 or under 15 years old were included, and this was purely based on the program in place in the location. So not influenced by the study. Written consent was obtained and assent for the children above 7 years of age. Children with signs of severity were excluded and immediately referred, and previous enrollment in a study was also an exclusion criteria. A brief questionnaire was made, especially on the history of malaria, and both RDTs, the PF, PLDH, and HRP2 were performed in parallel, and a dried blood spot was made from the same capillary blood draw. This was for molecular testing, which was done at the Australian Defence Force Malaria and Infectious Disease Institute, that is the WHO center for this purpose, where they looked at the genes of interest, so HRP2 and 3, PFLDH, and a human tubulin gene as a control. And this was done on all the RDT positives, either or both RDT, as well as a subset of 20% of the negative cases. The sample size, very quickly, was based on the WHO protocol with Bayesian methods and really aimed at being able to tell whether more or less than 5% of cases would be missed, and assuming a 60% HRP2 RDT positivity and that 8 out of 10 sites would be able to participate, which led to the ambition to have 200 suspect cases per site, or 2,000 cases in total. So on the main findings, 1,842 participants were enrolled between January and March 2024, with a median age of 3. And almost all of them were residents of the county for at least 30 days, except in Malakal, where 37% arrived within the last 30 days. This is relevant in terms of interpreting the data if differences are found, because they could be imported. The RDT results, 40% of HRP2 RDT were positive across the sites with variability between sites, and 32% of the PF-PLDH, so already showing quite a difference in sensitivity. Now for the results, this is a very busy slide, but it's the most important results. So what we were interested to see is cases that would be positive on the alternative test, so the PF-PLDH, and negative on our current test, the HRP2. So 14 of such cases were found, which is 2.4% of the total tests that were positive for PLDH. And when the molecular analysis was done, only 2 of these cases were actually confirmed to be due to P-falciparum, HRP2, and 3 double gene deletion. If you remember, if only one gene is deleted, the other one will still be detected. The others were due to other malaria species, P. ovale, P. malariae, or were negative for PCR, so possibly false positive RDT results. So in summary, to simplify it, less 0.34% of the total PF-PLDH positive tests were negative for HRP2, which is well under the 5%. And the 2 sites where one case was found remained also well under the 5%, even if that's not statistically significant. And of note, none of the cases which were negative for both RDT was found to have a gene deletion. So we didn't miss case that had, for example, very low level of infection. So in terms of the conclusions, luckily the deletions leading to false negative HRP2 tests were rare and well under the recommended cutoff. And for now, the current HRP2 RDT appear appropriate. We can reassure our clinicians, but also this has been informing the National Malaria Control Program and also our own MSF programs. A limitation is that there was a decent geographic cover of South Sudan, but mostly, as you could see, on the northeast and a bit in the south. So other areas might show different results because these are often very localized issues. So follow-up is needed, and a study is currently going on with Armauer Hansen Research Institute in Ethiopia, covering other areas. There were some questions on the RDT chosen for the study, the PFPLDH, because it detected some other species. So this is something WHO is aware of and following up with the manufacturers. It doesn't have an impact on the study conclusions, which were reassuring. But yes, whether this is the most appropriate test for such purposes. Some of the challenges and lessons learned from this survey, which was not as light as WHO was selling it, is that it took about a year of time and efforts to achieve a partnership between 4 parties, so MSF, the National Malaria Program, WHO, and the lab in Australia. Which was a huge effort, especially by Epicentre colleagues and Matt in particular, who led this. Of course, supervision in remote and difficult areas was hard, but we have pretty good programs and this was well achieved. The implementation delay led to missing seasonal peaks, which was not an issue because the results were very clear, the prevalence was very low, but had we been closer to the 5%, we would probably not have achieved a significant result. And on the positive side, the field side of things was relatively easy. To do 2 RDTs and take a DBS with a dedicated person was very feasible. And I'd like to thank our colleagues in Australia, especially Xin Cheng, who did all the testing, Matt, who did a lot of work, or most of the work to pull this together, and Jane Cunningham at WHO, who's been very helpful and continues to be very helpful in this area. Thank you.
Thanks so much, Erwan. And yeah, it's really important research and reassuring findings for now, but does really highlight the need for ongoing surveillance in the region. For our next presentation, first we have Jessica Sayyad Hilario. She is an epidemiologist at Epicentre for the last 10 years and holds a master's degree in public health from the Institut Pasteur. Before joining Epicentre, she worked in the field with MSF and also in headquarters in the operations department, and of course has been supporting the Chad mission for quite some years now. Then we have Nicholas Putney. He works at the Swiss Tropical and Public Health Institute, which is located in Basel, Switzerland, in the Analytics and Interventional Modelling group. Prior to being at Swiss TPH, he had a master's in statistics at the University of Geneva. And his current work is focusing on mathematical models and statistical methods to quantify the impact of malaria interventions with a particular focus on identifying strategies to really maximize public health benefit. So Jess and Nick are here today to share with us some key findings from a modelling study using routine malaria surveillance historical data from MSF's operations in Moïssala in the south of Chad. A data model has been developed to assess the effectiveness of seasonal malaria chemoprevention in order to develop some really concrete recommendations to inform the future operational strategy for SMC. Thank you.
Thanks. So we are happy to share with you the modeling of malaria routine surveillance data to inform SMC strategy in Moïssala, south of Chad. So to start with, what is SMC? SMC, seasonal malaria chemoprevention, aims to prevent malaria in children under 5 in areas of during the high transmission season, and consists of monthly administration of sulfadoxine, pyrimethamine, and amodiaquine during the rainy season. It has proven to be effective in reducing malaria morbidity and mortality, and it is recommended since 2012 by the WHO in countries with high transmission, highly seasonal malaria. Since 2022, it's also recommended in countries with longer transmission season with strategies tailored to the country's needs. So in Chad, malaria is the leading cause of morbidity and mortality, with more than 890 cases treated in under 5 in 2024. In Moïssala, South Chad, the incidence of malaria during the high transmission season is very high, with 40,000 cases in under 5 treated in average every year, from June to December. So now you can see on the slide a timeline with the evolution of the program in Moïssala and the weekly number of cases and the timing of the different rounds of SMC. So MSF program started in 2010, and the SMC started in 2012 and was progressively scaled up to the entire district with 4 rounds. In 2019, SMC stopped because it was not considered as an eligible area due to the long rainy season, but it was reauthorized in 2020. And in 2021, to take into account the longer rainy season, the Malaria National Control Program of Chad asked the addition of a 5th round to better cover the long transmission season. So this additional round was first implemented in November, and in 2023, the round was moved to June to cover the beginning of the rainy season. So here we are going to focus in 2018-2023 because we had access to a consistent data set from MSF. So as we have seen over the years, the number of rounds, 4 to 5, and the timing, starting months, have been implemented. They changed it. So we will call this the timing round, and the round the strategies. In addition, the number of cases are influenced by the timing, but also by the magnitude of the rain. But of course, the beginning of the SMC has to be decided ahead of the rainy season for obvious logistical reasons. So the objective of the model here is to inform what is the optimal strategy for SMC in Moïssala, and we defined optimal in terms of case averted using the routine data from 2018 to 2023.
Using only the data we have available, it may be difficult to determine the optimal SMC strategy. But by combining the data we do have with a mechanistic model of malaria transmission, we can answer more complex questions than if we were to rely on data alone. The mechanistic model represents malaria transmission dynamics with a set of mathematical equations. With our particular model, we account for many factors that influence malaria transmission dynamics, including incomplete reporting, SMC coverage, and a changing population. We also include real-time rainfall and temperature data, which influence the mosquito life cycle and therefore malaria transmission. Once we have our model, we calibrate it to the available data. In this case, our data is the number of weekly uncomplicated cases of malaria and those under 5 years old. Calibrating the model to data allows us to best represent the dynamics in our particular context. Now that we have our calibrated model, we can use it to assess different SMC strategies. These strategies could include, for example, 4 rounds or 5 rounds of SMC, or starting SMC in June or July. Shown here is the actual data, the observed number of weekly uncomplicated malaria cases, and here's the result of the model calibration process. The orange curve are the values given by the model, with the surrounding band representing the uncertainty interval. We see that our model is able to reasonably reproduce the malaria transmission dynamics in Moïssala. Now that we have some confidence our model is working well, we can use it to answer questions about different strategies. For example, what if there was SMC in 2019? What if a 5th round of SMC was not added into 2021? Or what if SMC in 2023 started in July and not June? We first explore malaria in Moïssala would have looked like in 2019 if SMC had not been stopped. The orange curve shows the strategy that was actually implemented, where there was no SMC in 2019. The shaded rectangles are the period where SMC was given. Now in blue is the alternative strategy where SMC was actually given in 2019. By comparing these two curves, we can quantify the impact of having stopped SMC in 2019. To better see the difference between the curves, we will zoom in on just the year of interest. Now comparing these curves, we estimate that about 11,200 cases would have been averted had SMC been given in 2019, translating to about a 19% reduction in cases during the high transmission season. This suggests that SMC is effective at preventing uncomplicated malaria in Moïssala. Now we try to quantify the impact of having added a fifth round of SMC in 2021 and 2022. Again, here in orange is the trajectory using the strategy that was implemented. So here that means doing 5 rounds of SMC, starting in July in 2021 and 2022. And we add to this what had been done previously, which was 4 rounds of SMC, starting in July. To measure the impact, we compare the difference between the two curves. Again, we zoom in to better see the difference. For illustrative purposes, we just show 2021, but the results are similar for 2022. Comparing these strategies, we estimate that there were about 2,660 less cases per year, doing 5 rounds compared with 4 rounds would have been done. This is about a further 6% reduction in cases and suggests adding a 5th round of SMC had an impact on reducing uncomplicated malaria. We now try to determine the impact of having moved the 5 rounds of SMC forward so that the first round begins in June instead of July. We take a similar approach here and compare the strategy that was actually implemented, where in 2023 SMC began in June, to what was done previously, where SMC started in July, shown here in blue. Like done previously, we take a closer look at the year of interest. Here we have the number of malaria cases in 2023 on top, and rainfall in the plot below. We see that by putting the first round of SMC in June instead of July, the peak in cases at the start of the rainy season is prevented. On the other hand, starting in July and finishing in November prevents the small rebound that occurs towards the end of the rainy season. Looking at the difference between the strategies yields an estimated 580 less cases when starting in June instead of July, which is about a further 1% reduction in cases during the high transmission season. Although the difference in cases between strategies is small, the results suggest that starting in June helps reduce the peak in cases at the beginning of the season, which may help to not overwhelm the health system. We have shown that having added a 5th round of SMC in 2021 and moving SMC to start in June in 2023 likely had positive impacts on reducing the malaria burden. But the optimal strategy may differ year to year based on rainfall and temperature patterns. Now we try to determine what would have been the optimal strategy over the entire time period from 2018 to 2023 to account for these potential differences. We assess the 3 strategies actually implemented, so 4 rounds of SMC starting in July and 5 rounds of SMC starting in June or July. We also test one additional strategy of 4 rounds of SMC, with the first round being in June. Each strategy will be compared to a baseline. Here the baseline is the original strategy of 4 rounds of SMC starting in July. And we are assuming an SMC coverage of 86% for each round, so we compare the strategies themselves and not differences in coverage. We start with the baseline strategy, again 4 rounds of SMC with the first round in July. On the left is the reduction in cases compared to this baseline, and the right is the weekly cases from 2018 to 2023 under the given strategy. We now compare this baseline to 4 rounds of SMC starting in June, where we see little difference over starting in July. However, adding a 5th round has a pronounced impact, and shifting the first round to June leads to a further reduction in cases. These results provide additional evidence that the current strategy being deployed in Moïssala, 5 rounds of SMC starting in June, has the greatest impact on reducing uncomplicated malaria cases in those under 5 years old.
So the study shows that SMC has an important impact on the malaria burden in Moïssala, but optimizing the strategy could even help reduce further the cases. So the mechanistic model is a powerful tool to test hypotheses and inform SMC strategies tailored to the context. Other hypotheses can also be tested, like changing the age of inclusion in SMC, changes in rains or climate changes, or also interval between rounds. But the recommendation could also evolve as the rainy season and climate change. However, some limitations have to be mentioned. The model is always a simplification of the reality, and in our case, for instance, it does not take into account the spatial heterogeneity of the district within Moïssala. Secondly, model outputs are as good as the data used, and changes in case reporting or a certain uncertainty in coverage data can affect the model output. So there are some next steps planned. So we are going to integrate new data into the model, such as severe cases and death, sub-district level data in Moïssala, and previous years and more recent years. And finally, the model will be extended to include the RT21 vaccine that will be rolled out for the first time in June 2025 with SMC, and that should help to define the best strategy. Thank you. So finally, we want to thank our colleagues at MSF in Jamena, Paris, and Moïssala, and the PNLP team, and also Swiss TPH and Epicentre, especially Clara and Anton. Thank you.
And I'd just like to add a thank you to Jess and Nick for presenting this important research. I think it's a really nice example of how one of these mechanistic models can have a really direct and quite timely impact and help serve our operations. Pour la prochaine étape, nous allons
So now we're going to switch to French.
So
we have the great pleasure to introduce Dr. Mohamed Sekadia, who is the director of the National Program of Malaria fight against malaria in Chad. He's going to provide us with an overview of what is available to fight against malaria in Chad. And SMC is one of those tools. He's also going to talk about how data analysis and SMC is helping to inform the implementation strategies, and also to provide for continuous funding in order to provide for essential actions against malaria in Chad. Dr. Diaz, you have the floor.
Merci Sakim. Bonjour à tous et merci de nous recevoir. Pour moi, c'est la première.
Okay, so thank you very much. This is my first participation in the scientific day at Epicentre, although we've been working with MSF teams for some time now.
Nous, en tant que programme,
so as a program in Chad and the fight against malaria, we implement a strategy or strategies that are implemented in many parts in Africa, especially in sub-Saharan Africa.
Le programme,
so this program is tasked with drafting guidelines, directives, and to make sure that they are being implemented and complied with. It's also tasked with providing with the financing, offering strategies. And our strategy is a canal. And in our plan, we have various intervention strategies that include management strategies and prevention strategies. When it comes to management strategies, we are testing with RTDs and sanitary trainings. We train people, we make sure that we manage malaria at the community level also. And we are also integrating some private clinics, for-profit clinics, so that they can collect data for us. We also have prevention actions, for example, including SMC. We also promote the use of a mosquito net, so we distribute those nets every 3 years. And we also have this routine distribution on a yearly basis for pregnant women and children under the age of 5. In some areas, we also spray products inside the households. We also do SMC. SMC is we're one of the forerunners back in 2013, and we have moved forward. We now extend the strategy at various levels. When we started out, we were following the guidelines of the WHO. It has to be an area in which it's a seasonal transmission, a seasonal malaria. And Moïssala wasn't part of the areas in which we were present. So MSF took this initiative and implemented SMC in Moïssala. And as it was said during the presentation, Moïssala wasn't complying with some of the criteria, because it's not just about seasonality of the rainfall, but it's also about case transmission. So 60% of the cases have to be transmitted during that period, etc., etc. So the strategy was stopped in 2019, as was said. So we worked with MSF, and it was a joint willingness to really change things in order to meet the needs. The southern part of Chad is the most highly populated area, and 60% of the malaria cases and death took place at national level. We're in this area. So the impact of malaria is very high, but they didn't benefit from SMC. So it was a opportunity for us to see whether the strategy would help us maybe to meet an unmet need and to cover those children, because they are the most vulnerable people. And this has been why we reviewed our strategy, and we worked together in order to extend the number of rounds, so that during the rainy season, children are better protected, because this rainy season can last from July until December. So this is part of our advocacy efforts. If we implement the strategy in Moïssala, the evidence that will come out of this will help us justify that even though it doesn't necessarily meet all the criteria, we can prove that in a highly endemic area, transmission is highly seasonal. So the findings that you've seen clearly show that between June and December, this is really the time when we have a peak number of cases. And if we adopt this strategy, this allows to drastically reduce the number of cases. This has allowed us also to do a stratification. We now have extended this at the national level, expanded it at the national level, and we are now reviewing the way we plan our strategy. Where can we do SMC? Everything is reviewed with the stratification parameter. Where should we distribute mosquito nets? Where should we have a nets plus SMC? Where should we spray, etc.? And this really allows us to be extremely precise when we ask for some funding from the Global Fund for 2024-2027. But unfortunately, there was this funding issue, and we're not able to cover all districts, all areas, but we're able to review our priorities and to decide where to implement SMC. And we have added additional areas where there is a higher periodicity, in the transmission of malaria, and we're still thinking about implementing SMC in those areas. And I also forgot to talk about prevention. We have added the vaccine that we launched in October, and the director in charge of vaccination is here. She can also answer questions. And this strategy, the stratification strategy, allows us to really prioritize where the areas where we're going to implement the various strategies in order to make sure that we use the right resources where we can have the greatest impact. Thank you.
Merci, Dr. Diar.
Thank you so much, Dr. Diar. I really wanted to highlight, to pick up on one of those last items. When we talk about malaria, really it's about a sub-national approach. It's not a one-size-fits-all for the entire country. So it's important to have this stratification work and to see what kind of actions will be most impactful. With the introduction of anti-malaria vaccines, things are going to change, obviously. Now, we are going to discuss the issue of the anti-malaria vaccine, because in June 2025, in collaboration with the Ministry of Health in Chad and MSF France, Epicentre is going to launch in Moïssala a randomized trial, a cluster trial, in order to compare two implementation strategies in an environment in which you already have SMC, and one arm is going to provide the vaccine to children under the age of 5, and this will be done together with SMC, so SMC plus vaccine. The global experience from other countries that have already introduced this last year has highlighted some challenges that need to be taken into account. The vaccine is, well, it's a bit complicated because it's a 3-dose scheme, and you have to have all 3 doses. So that's during the first year of life, and during the second year of life, it's important to add an additional dose of the vaccine. Obviously, this means that there are various challenges for the Ministry of Health. First, the cost of the vaccine and the multiple additional visits, and also logistical issues for the cold chain. And the global experience following the introduction of the vaccine in other countries has demonstrated that it is really difficult to obtain a good coverage and have this 3rd dose. It's not 100% efficient, but previous studies show that the combination of several prevention measures is essential and also has some synergy. So the malaria vaccine was introduced back in October 2024 with 2 antigens, PCV and rotavirus. This is a very ambitious approach. It is a child-centered and really targets 3 of the main causes of death in children. So I'd like to introduce Dr. Antoinette Demia, who is the Director of Vaccination, Fight Against the Disease and Epidemiological Surveillance, and she's going to present the main findings of this program. It's also going to share some ideas and findings after the introduction of the anti-malaria vaccine. Thank you so much. Good afternoon, everyone. Very pleased to be here with you today. Regarding the introduction of the vaccine in Chad, this malaria vaccine is probably the vaccine that the African continent has been really being looking forward to very much. In Chad, you have pneumonia and diarrhea. They are the two main causes of mortality in Chad, and we introduced all three vaccines at the same time in October. But what mothers were really looking for was the anti-malaria vaccine. So during the first days following the introduction of vaccine, we had some shortage because all mothers were bringing their children to have them vaccinated. Some of them were even saying that their children were younger. So we said the children had to be 6 months old for the first dose, and we ended up vaccinating children aged between 7 and 12 years. And once you have a mother with a child, you're not going to refuse to provide the vaccine because this could have an impact on the antigens. And after 2 weeks, we issued a note in order to try and regulate things. There was a small impact, but very limited because everyone wants to have the vaccine. Adults also wanted to have the vaccine. And the main challenge was that people tended to think that it was a kind of a magic wand, and that once you have the vaccine, there is no need for any prevention measures. Even one agent told us that since the twins had been vaccinated, there was no need for the mosquito net because the daughters had the 2 doses and they didn't need the mosquito net. And we said, no, you need all 4 doses. You also need to associate this with other prevention strategies. There's also another issue or challenge. We have a 98% coverage for the 2 doses, but 48% for the 3 doses and 5% for the 4 doses, because you really need to communicate very well upstream and explain that it's important to have all 4 doses. Also, one advantage is that we studied the acceptability of the vaccine, because the 3rd dose is at 9 months, and at 9 months we have 5 antigens, and we fear that mothers are going to refuse because there are multiple injections. But with this malaria vaccine, we were able to take care of under-immunized children, and we also have more mothers going to doctors with their children for the vaccine, and they were also talking about other health issues instead of self-medicating at home. But we still have to work on communication because people tend to believe that as soon as they have had the vaccine, they don't have to do anything else, that it is self-sufficient. So on the 15th of June, we're going to start a new study, which is very timely. It will be two arms, first a routine vaccination scheme, and the other arm will be the vaccination campaign plus SMC. So we really have high expectations. It will be Moïssala and Dambo, 2 districts in which the incidence rate is very high, and we hope that this will help us review our strategy and maybe change things when it comes to preventing malaria in our country. Thank you, Antoinette. I really do believe that Antoinette has highlighted many important aspects. Awareness raising first, really important to raise awareness about this new vaccine for people in the community, but also for healthcare workers, so that they get the message. For now, we do not exactly know which strategy is best. There is some evidence in a seasonal context to have the right timing, but when you do this at scale, you need some evidence. So we hope that next year maybe we'll be able to provide you with some findings on this. I think we have 2 minutes left for a short Q&A session.
Bonjour à tous.
So, good afternoon, everyone. I'm Olivier. I'm a medical coordinator in Chad. And I'd like to commend both of you for being here today because we've been working with you in order to fight against malaria. Because of a time constraint, I'm going to be brief. Would like to commend your presentation and talking about SMC, as you know, malaria chemoprevention. This can evolve because we have climate change, and with climate change, the rainfall started back in May in the southern part of the country, and that can last until December. In the past, SMC was done between July and October. Then it was extended to November. 4 to 5 rounds, but with climate change, rainfall, the rainy season is longer. And I'd like also to mention the fact that SMC has evolved quite a bit. In the beginning, it was now we have more and more floodings, and instead of having centers that people go to get the chemoprevention, now people go door to door to their households, and there was also the other prevention that was used in Chad that is part of our prevention efforts. I also would like to say that we're seeing the real impact of SMC in our hospitals, in our offices. We usually see a reduced number of people being admitted to hospital for malaria, because even though people do not necessarily live in Moïssala, what MSF is doing in Moïssala is seen as a benchmark, and this helps us have more children benefiting from those schemes. And this study that will take place together with the Ministry of Health will hopefully help us build even stronger strategies. Thank you. Dr. Dia, do you want to add anything, any feedback? Because we haven't really had the opportunity to talk about the impact of climate change, but this is going to make things more complicated indeed.
Alors, la question du changement climatique,
talking about climate change,
ça doit être
I believe
obligatoire même dans
that it should be taken into account when you want to fight malaria. You have to obviously take into account the environment in which you live, with the floods that we are seeing in sub-Saharan Africa mostly. They usually take place every 2 years, and for example 2022, 2024, etc. And those floods impact the transmission of malaria. Either it expands the transmission period, but it also impacts the intensity of this transmission and the aggressiveness of the vectors. And we've also seen other vectors arise that are more aggressive, like Safandia and others. So if you want to fight malaria, we really needed to take into account this environmental aspect. And the impact study on malaria that was done in Yemen after the floods has shown quite clearly that the high transmission period that should have ended in October, from July to October, we noticed that after the floods in 2022, well, there were some larvae that were still active in some areas, and they were still producing mosquitoes until December. So malaria was present until December. So it's important to really include those environmental aspects into our reflections. And it's important to really understand that the transmission period is now longer. Well, thank you. If I may add to this, with this study together with the MOH, one assumption is that we could vaccinate people at the beginning of the rain season, and this could maybe also protect people until the end of the season that is now longer, as we are seeing. So it's an assumption, but thanks to the study and others, we're going to be able to inform our decisions and to fight malaria in a more efficient way. Another question, Marilyn Bonnet. Quite recently, I discovered SMC in Cameroon, and indeed, it is very well accepted. It's also promoted by the MOH programs, but it is quite cumbersome. It mobilizes all healthcare resources over a 4-month period of time. In the community, lots of logistics also, and you have the international situation, lower fundings with the Prevention Malaria Initiative. For example, in Cameroon, they almost got no funding for the 2025 SMC. Thanks to a US foundation, they were able to still do it. But, are there any solutions or possibilities to simplify things maybe with those models? Could we maybe find strategies that would be less costly or more simple to implement in order to make sure that those prevention measures still remain, even though funds tend to be cut? It's not just from the US, no, even AFD, no French funding is seeing a 40% decrease. So we need to be realistic, beyond what MSF is doing. Don't you think so? Well, thank you so much for this question. I do not think we can go into many details today, but obviously with less funding, with more constrained financing, now is a time to go for integration. So it has always been the case with malaria, but how can we proceed? Well, now, maybe Dr. Dia would like to add to this. Well, I will answer your question.
Oui, pendant longtemps,
for a long time,
le Tchad n'est pas PMI depuis plusieurs années déjà, et on disait malheureusement pas PMI. Aujourd'hui, avec ce qui se passe, on dit plutôt heureusement qu'on n'est pas PMI parce qu'il y a beaucoup de pays.
We're quite happy not to be a PMI because many countries were looking forward to this financing, such as Burkina Faso and Togo, and now they are deprived of several millions in funding that were used to pay for SMC. Now you need to look for funding in order to pay for this SMC, but as a country, we take to talk about long-lasting investments, sustainable investments, etc. I also realized that when there is a vaccination campaign, it's not that cumbersome, but when it comes to malaria, it is actually quite heavy and very demanding. What we want to experiment is SMC at the community level. This will be a pilot study that will begin in 2026, and we will provide community health officers with the drug so that they can do things at the community level and provide the prevention, the drug to the children that they look after at the community level. So we're going to ask those officers to carry out a national task, and they will administer the prevention drug to children under 5. So it's a pilot strategy that we want to experiment with the global fund financing, and we're going to see whether this is going to have an impact on the coverage or not. And this pilot study will provide us with some evidence, and if the evidence is in line with our expectations or assumptions. In other words, allow for a good coverage of all the children under 5. This can then be done routinely and also help us save money and make better use of our funds. I have a question, Delphine Sauvageau. I'm an epidemiologist. Well, vaccines may mean a lot of hope, and we hope that it will have a huge impact. But what about an exposure during the vaccination process? Now, before the 3 doses have been given, and even before the boosters. So, would an actual exposure have a booster effect in part, or could this be also part of a strategy in order to simplify this critical period? I have another question. It might not be the case in Chad, but in many countries we'll have dengue, which is another vector. So would there be any cross reactions or any cumulative effect of both? Do you know anything about this?
Merci.
Thank you.
En fait, le vaccin palu.
Well, the anti-malaria vaccine, we do not have enough information when it comes to natural exposure.
Avant, c'était juste le RTSS.
It used to be R21 and RTCS only, but when it comes to natural exposure having a boost effect, I don't think this is really the case, because even the vaccine doesn't have a 100% efficiency because it has to be treated with other anti-malaria strategies. So scientists are really working on a vaccine that will be 100% efficient, and we hope that this will take place not too long of a time. As for dengue in Chad, we didn't have any dengue, but with the inflows of refugees from Sudan, we've started to have some dengue cases in 2023, and I think that this will be included in the Gavi cycle starting in 2026. And we are working on the documents in order to have access to those dengue vaccines. But we are really talking about the dengue vaccines, R21. And with this inflows of refugees in Chad, we are seeing new outbreaks, TAPSI, meningitis, dengue, many diseases that are associated with the arrival of our brothers and sisters from Sudan. Thank you. Well, I have a question on this side of the room. So this has more to do with the operations. Regarding the implementation of SMC programs in the field, as was said, in most countries, the first doses are given by healthcare agents, and then the other doses are given by the mother. What about Chad? What kind of strategy do you implement in the field? And if you want to add this to associate it with the vaccine, how are you going to administer the doses at home and vaccinate our children at home? So how do you intend to do this? How do you intend to have both strategies being carried out at the same time? Well, maybe you can start and I will add to your answer. Well, I will answer and talk about SMC. In 2024, we administered SMC in 88 health areas. SMC is 3 days to distribute the drug, and 1/4 day to do some outreach. And we don't have much funding to expand. I mean, either you work longer or you add people if you want to expand. And both options are costly. And what about the second and third day? Is the drug really administered by the parents? So what we do is that the first dose is done by community health care workers, but second and third days, then this is done by the parents. We work with some partners just like the consortium, and we try and see how things are being done. But this is really one of the things that we should look into and do some research. And if a student is interested, we have the campaign in 2025 and going to try and see if the parents actually give the prevention drug during the second and third days. But the current strategy is first day by the healthcare worker and second and third days by the parents. Now, regarding the combination of strategies, this is a study in Moïssala and Dembu, more than 20 healthcare centers. So the campaign will start in June, that's for SMC, and we're going to monitor those children on a regular basis. There will be a tracker. A tracer, sorry. And for the 4 doses of vaccination, there will also be some follow-up, and we are going to get in touch with the parents to make sure that things are done at home the way they should be, and also make sure that people go to the healthcare centers to get all doses of the vaccine. For now, it's a small scale, so it's quite easy to do, and we'll make sure that this can be upscaled afterwards. Well, if I may add to this, when we were preparing those strategies, it really is about raising awareness. For some months now, we've been working together with colleagues at the Ministry of Health and also with the heads of villages, with mothers, in order to really insist on the importance of continuing with SMC and making sure that children get all 3 doses as planned. And now with the vaccine, we're going to really insist on the fact that you need to have the 3-dose scheme and the booster dose next year. Yeah, I apologize. I know that there are still some questions in the room. Please don't hesitate. Come and talk to us after the session. Thank you. I'd like to thank everyone. I'd like to thank all the panelists and our 2 colleagues, Dr. Dia and Dr. Antoinette Gela.